In this masterclass, we're going to learn about Cushing Syndrome. So what is Cushing Syndrome? It is basically a clinical syndrome caused by chronic exposure to increased glucocorticoids. Okay, so it's basically a clinical syndrome caused by increase in the exposure, chronic exposure of glucocorticoids. Let's look at the causes, and probably the causes and how do we diagnose this Cushing syndrome are the two most important part of this video lecture. So let's have a detailed look on what are the causes. So causes can be divided into exogenous causes or endogenous causes. Exogenous also is basically iatrogenic, which means we have prescribed steroid for some particular condition like nephrotic syndrome or any other autoimmune disorder, and because of the side effect of that particular steroid which we have been given for very long time, the patient starts developing symptoms of Cushing syndrome. So that is iatrogenic, or maybe he's taking some ayurvedic supplement or some supplement which has steroids into it and the person is using it for very long time. So that again comes under the exogenous category. And remember, overall, it is the most common cause for Cushing syndrome. So exogenous causes are the most common cause of Cushing syndrome. Let's look at one more important point which I want to highlight here is they are all ACTH independent, which means they are not because of the increase in the ACTH level. In fact, in all ACTH independent condition, actually the value of adrenocorticotropic hormone will be decreased. Okay, let's look at the endogenous causes. So when we talk about endogenous causes, again it is divided into ACTH dependent and ACTH independent, which means that the cortisol level, is it increased because of the ACTH or is it rising independent of ACTH? So in ACTH independent, we will have adrenal adenoma or carcinoma. So there is an adrenal adenoma or carcinoma which in itself is producing cortisol. So this is ACTH independent. Remember, in this case again, ACTH level will be decreased. Let's talk about ACTH dependent. So here we have pituitary adenoma, which means in pituitary there is an adenoma which produces adrenocorticotropic hormone, which further stimulates the adrenal gland to produce more cortisol. So this is also called as, and let me put it in red, this is also called as Cushing disease. Okay, so basically remember, Cushing disease is a special cause or one of the causes of Cushing syndrome, and this is primarily due to pituitary adenoma. Okay, remember, overall it is the most common cause of endogenous Cushing syndrome. Okay, like we said that overall most common cause of Cushing syndrome is iatrogenic. Most common cause of endogenous Cushing syndrome is your Cushing disease, that is pituitary adenoma. The second sources or other sources of ectopic ACTH production will be small cell cancer, lung cancer, also called as oat cell cancer, okay, of lung, which will produce ACTH. Also some atypical, not the typical carcinoid, but atypical carcinoid tumor, especially of lung, okay, especially of lung, again will produce adrenocorticotropic hormone, which will lead to increased stimulation of adrenal gland, leading to more production of cortisol. So in all these cases, remember, ACTH level will be increased. Okay, so here ACTH level will be decreased, in this ACTH level will be decreased, but in these cases ACTH dependent, the ACTH level will be increased. So remember, in all those cases cortisol level will be increased, but ACTH level will increase or decrease depending upon the cause. So this is, we have looked at the causes. Let's look at the clinical features and pathogenesis. So I will discuss both clinical features and pathogenesis together. Okay, so remember, there are two mechanisms by which the pathogenesis is manifested. So number one is increase in the cortisol level, and in some of these cases there will be increase in adrenocorticotropic hormone. So let's discuss this because this is easier. So adrenocorticotropic hormone also acts on the melanocyte stimulating hormone receptors, okay, and this leads to hyperpigmentation. So in all those cases where ACTH level is increased, you will have hyperpigmentation. Where are these hyperpigmentation found? So they can be found in sun exposed areas. What are the sun exposed area we are talking about? Face, arms, neck, face, arms, neck. They are also on pressure points. Okay. What are the pressure points? Knee, elbow, and knuckles, creases, palmar creases. They are also found in perianal region or groin region. There is increased pigmentation. Also, there can be increased pigmentation in the tongue and the buccal mucosa. So these specific places, there will be increased pigmentation, hyperpigmentation. So hyperpigmentation generally is pointing towards some kind of cancer or tumor, and this is primarily due to the increase in the adrenocorticotropic hormone. Let's look at what will be the effects of increased cortisol in patients of Cushing disease. So this is responsible for most of the effects. So the first important effect which increased cortisol will lead to is fat redistribution. So I'll tell you what exactly will happen because of the fat redistribution in the body. Just let me tell you what are the important mechanisms by which it will act. Another important thing is there will be increase in the protein catabolism, increase gluconeogenesis, 6 steroid receptor stimulation, and lastly there will be stimulation of aldosterone receptors or ENaC receptors. Okay, so let's look at the effect of each of these in detail. So because what will happen because of fat redistribution? So one important thing about with fat redistribution you will have is lemon on stick appearance, which means there is a centripetal fat distribution. So the central obesity is there with limbs being thin. So central obesity with thin limbs. Okay. Also, there will be moon faces. Okay. Because of the fat deposition, there will be also hump or neck hump. So all these things will happen because of the fat redistribution. What will happen due to the protein catabolism? So remember, number one, proximal muscle weakness or proximal myopathy will happen, osteoporosis. Also, there will be skin thinning. So skin will become thin, easy bruise, and stria development. These stria, remember, classically they are purple or violet in color. Okay. What will happen because of gluconeogenesis? So it will cause increase in blood sugar, and this is one of the causes of secondary diabetes mellitus. Okay, because of Cushing's disease you are having increase in blood sugar, so this is one of the causes of secondary diabetes mellitus. What will happen because of the sixth steroid receptor stimulation, especially in female? You will have hirsutism, menstrual abnormalities. Okay, so these are seen. Remember, when only menstrual abnormalities and hirsutism, so you will have to first think of PCOS, And only when you have additional features of Cushing disease, then only you will, or Cushing syndrome, then only you will go for the diagnosis of that. Otherwise, in a female patient with hirsutism, menstrual abnormalities, those features, you will first think of PCOS, and then once you have ruled out PCOS, then only you will think of Cushing syndrome. This is very important when you are, trying to solve MCQs. What happens because of ENaC receptor? So, what does the ENaC receptors do? So, it will pull out sodium and water, and it will push in potassium and hydrogen ions. So, what is going to happen basically is the potassium level is going to decrease. So, they will be hypokalemic, and because even in the urine hydrogen ions are excreted, they will be metabolic alkalosis, like you see in Crohn's disease or hyperaldosteronism. So, there will be hypokalemic metabolic acidosis, and because water is retained with sodium, you will also have hypertension develop. Okay, so these are various features. Overall, if you see, all these things will predispose to a lot of metabolic, disorders or metabolic manifestations. Important being weight gain. So all these patients will have a lot of weight gain. There will also be, with gain, there will be dyslipidemias because of the increase in the insulin resistance, and all these weight gain and all these metabolic features, remember, they will be development of hypertension. So this is, very logical way I have tried to explain what will be the increased cortisol manifestation in these patients. So fat redistribution, protein catabolism, gluconeogenesis, sex steroid receptor hormone stimulations, and ENaC. So ENaC or aldosterone receptor stimulation. So all these are the various pathogenetic mechanisms and clinical features of Cushing syndrome. Let's now move forward and see how we will move about with diagnosis of Cushing syndrome. So, for diagnosis, step 1, we have to, identify hypercortisolism, which means increase in cortisol level. So, there are very easy mechanism. First is we can go for 24-hour urinary cortisol level. Okay, and why we go for 24 hours is because the diurnal variation is very, very, we have seen that there is a diurnal variation in these cases. So 24-hour urinary cortisol level will ensure that your sample is indicative of the 24-hour cortisol levels. Next is, because very interestingly, one of the first thing to be lost in a Cushing syndrome patient is the diurnal variation. Normally, you know that, suppose this is the time and this is the level of cortisol. So generally, let's say you wake up at 6 a.m. So when you are asleep, the cortisol level is lowest, and as you are about to wake, it will keep increasing, and towards the end of the day, when you again go to sleep, it will keep going down. But what happens in Cushing disease is this diurnal variation is lost. So your cortisol level will be increased throughout the day. And how do we check for cortisol's level increase throughout the day or spot cortisol level? Generally, we do a salivary. So, in saliva, we can check the cortisol level. This is more indicative of the spot cortisol levels. Okay. Then also, we can go for a low dose dexamethasone suppression test. So what happens is we give low dose dexamethasone 0.5 milligram every 6 hourly, and we see if there is a suppression of the cortisol levels. So what happens if it is a ACTH, dependent, ACTH dependent causes like pituitary adenoma or small cell cancer, then there will be a decrease in the cortisol level. But if it is ACTH independent causes like iatrogenic or adrenal tumor, then there will be no effect of low dose dexamethasone test. And this is also the investigation of choice which has been asked in the examination. So once we have identified if there is an hypercortisolism, that is increase in cortisol level, the next step will be to identify the cause. Okay, so how do we identify the cause? So first foremost test will be, we can go for a serum ACTH level, which will tell us that if the ACTH, because based on that we can go for the what are the differential diagnosis. Next is we have to go for high dose dexamethasone suppression test. So in low dose we were giving 0.5 milligram every 6 hourly. In high dose we will give 2 milligram every 6 hourly. Okay, and then we will see the cortisol levels. Now this is to differentiate between different causes of ACTH dependent, because if it is a pituitary adenoma, okay, there will be a complete suppression of cortisol. So cortisol level will almost come to normal. But if it is like something like a small cell lung cancer, then or oat cell cancer basically, then there will be the depression in the cortisol level will be very minimal. So high dose dexamethasone suppression test is done to differentiate between pituitary adenoma and other ectopic sources of ACTH production. So this is here. We can also go for imaging techniques. So depending upon what we are suspecting, suppose we are suspecting a pituitary adenoma, then the imaging modality will be MRI of brain. If we are suspecting any adrenal tumor, then we will go for CET abdomen. So in the exam, they may ask a question that what is the imaging modality of choice in case of endogenous ACTH dependent Cushing syndrome. So ACTH dependent Cushing syndrome, we are primarily thinking of pituitary adenoma, then the correct choice will become MRI brain. If it says endogenous ACTH independent Cushing syndrome. So ACTH independent, when we talk about endogenous, primarily we are talking about adrenal carcinoma or tumor, then we go for CET abdomen. So based on what they have put it in the question, we'll have to answer it. So these are the imaging modalities. Let's look at how we will manage the patient. Okay. So if the cause is iatrogenic, which is the most common cause overall of Cushing syndrome, so remember we will first taper and stop steroids. So another very important question is, why do we taper steroids? Because if we suddenly because the adrenal capacity to produce a steroid is decreased because we are supplementing steroids from outside. If we suddenly stop it, adrenal gland may not be able to immediately produce that amount of steroid, and this will lead to something called as Addisonian crisis, which is a basically medical emergency, acute medical emergency. Okay, and here you will have decreased blood pressure, decreased sugar levels, and they can be increased potassium levels, and all these are very, very life threatening. Also, because you use steroid for various autoimmune disorders, and when you have stopped steroid, though there will be chances of flaring up of those autoimmune disorders. So we use steroid sparing agents. So there are multiple steroid sparing agents, and we have created a specific masterclass on steroid sparing agents. So please go through that. So that is iatrogenic. If the cause is Cushing disease, remember Cushing disease we refer only when we are talking about pituitary adenoma. Only when we are talking about pituitary adenoma, we call this Cushing syndrome as Cushing disease. So if it is Cushing disease, the definitive treatment will be surgery. So it's transsphenoidal, removal of the pituitary adenoma, or nowadays there is also stereotactic radiosurgery. If surgery is not possible, then we can also go for bilateral adrenal gland removal. Okay, so that also can be done. Next is, if we have adrenal gland tumor carcinoma, then in that case we start with medical adrenalectomy. So we give some drugs which will reduce the production of adrenal gland. And what are these drugs? Ketoconazole, mitotane, etomidate. So all these drugs you will be learning in your pharmacology. So these are the drugs which are used for medical adrenalectomy. Also, the definitive treatment is surgical removal. So here there is a basically syndrome called as Nelson syndrome. Now, Nelson syndrome is patient of adrenal tumor which after surgery. So bilateral adrenal tumor which has been removed. So patient is on hydrocortisone, and because of the increase in the adrenocorticotropic hormone, because you are supplementing the glucocorticoid hydrocortisone from exterior. So what happens is there is increased in the ACTH production, and these patients will have hyperpigmentation. So just remember, Nelson syndrome is basically bilateral adrenal removal, patients of bilateral adrenalectomy. Lastly, if there is ectopic sources like small cell lung cancer or atypical carcinoid syndrome, surgical removal or chemotherapy depending upon the treatment regime. Okay, so this completes our discussion on Cushing syndrome, and mostly you will get questions on causes and diagnosis of this particular condition.